reading the questions? Any volunteer? Just let me know in the chat or elsewhere. Let me know that if anyone interested, or just raise the hand button down below. Anyone want to read the questions? Yeah. Dr. Ghada, Dr. Muhammad, Dr. Rania, Dr. Koro, Dr. Zuhail. Yeah. Anyone, please. Just unmute yourself on the mic and read the questions with me. For instance, Dr. Ghada, are you here? Dr. Ghada Hassan? Yes, Dr. Ghada Hassan, are you there? Dr. Haider said B. Okay, would you be please interested in reading this question first and tell us why is it B? So you're rightly so. You said that, what did you say? You said it's B, which is ruptured ectopic pregnancy. Is that right? But why not other things like appendicitis or an appendicular abscess? Or why it made you very focused on ruptured ectopic pregnancy? Mm-hmm. So, okay, the reason being is that someone who is in profound hypovolemic shock with an acute abdomen and there is large collection, it is likely that there's intraperitoneal bleeding. Is that right? Most likely there's intraperitoneal bleeding. So rightly so, you said that this is ruptured ectopic pregnancy. That's the correct answer, right? So for this question, it is option B. Yes, anyone please just help me out, read the next question. Yeah, anyone?
Yes, yes.
Sure.
Doctor.
Okay,
Yeah,
welcome,
yeah.
Dr. Nouri. How are you
Thank
doing?
you, sir. I'm fine. How about you?
A little bit under the weather today, so excuse me, everyone. My voice is a bit. There's some kind of upper respiratory situation.
Yeah.
So anyway,
Okay.
can you
Question.
please? Yeah.
Thank you. Thank you. Question 27. During a fight outstretched gallop, 20 years old man sustained blow to the face by the elbow. He subsequently presented to emergency department a breast epistaxis association with orbital swelling. Which of the following is a most likely damage? Nasal bone, smooth bone, maxillary bone, sarcoma, and so in this patient, blow to face. Okay, he also have pre-hospital swelling, epistaxis. I think. I think. I think. I think it's a fracture of. Okay, nasal bone, smooth bone. Okay, pre-orbital swelling. Breast epistaxis. I will go nasal bone, smooth bone.
Ethmoid. Okay.
Yeah.
So yeah, that's correct. Very good job. That's nasoethmoidal fracture. Nasoethmoidal fractures are commonly associated with bilateral severe periorbital swelling on both sides, and it tends to be a massive swelling, not just like any swelling. It tends to be so massive, in addition to epistaxis, because the ethmoid bone contribute to the medial wall of both orbits, right? What is that, if I may ask, what's that plate of bone, when someone that have orbital cellulitis, or the reverse, when someone have ethmoiditis, why might they develop easily periorbital cellulitis? Yeah, nothing on the screen? I'm sharing the screen. It should work. Yeah, I'm sharing the screen.
Yeah, it should work. It should work.
So if I tell you that someone that have ethmoiditis, suppose you're in the OSCE exam, inshallah, when everyone here passes part A, you get the OSCE, the examiner tell you why in ethmoiditis patients can easily develop periorbital cellulitis. What's the answer if you got asked that question? What would you answer? The answer is because there's a very thin plate of bone only, very thin plate. It's not the cribriform plate. It's called lamina papyracea. Lamina papyracea. And it's a very thin plate of bone between the ethmoid air cells and the orbit. And some people, they have defect in this bone. Sometimes naturally and anatomically, there isn't even a barrier. And if the barrier is there, it could be very thin. So that's correct. Okay, I ask you, sorry, I ask you another question. What if, in addition to this picture, in this case, they have periorbital swelling, they have brisk epistaxis, but they have malocclusion, also malocclusion? What will be the answer?
I think malocclusion is something about the maxilla.
Yeah, excellent. So if there is bilateral periorbital swelling, epistaxis, in addition to malocclusion, there must be bilateral maxillary fracture on both sides. But in this case, as you said, ethmoid. Yeah. So what about the next question? Yes.
Yes, question 28. Following a road traffic accident, 30 years old female present with severe headache, persistence formatting CT scan show by convex shape collection over the temporoparietal area. Which of the following is most likely? I think this is by convex. I think this is epidural hematoma. So
Yeah.
I think it's a middle meningeal artery.
Excellent. Yeah. So it's middle meningeal artery. Most common vessel involved or implicated in epidural hematoma. Yes, so epidural hematomas mostly there are arterial bleeds, is that right? Mostly arterial.
Yeah.
There could be venous if there is injury to the dural venous sinuses. There could be venous bleed also, but this is uncommon. So, which is more common, epidural or subdural? More commonly seen in practice, epidural or subdural hematoma? Yeah, so subdural are more common. Subdural hematomas are much more common than epidural hematomas, which is some people always think that epidural is more common because it's just famous, okay? But it's not. So subdural is not that famous, but it is in fact more common. Is that right? And it's mostly venous. Subdural hemorrhages are mostly venous, commonly seen in young children, child abuse, commonly seen in the elderly, alcoholic people, these things. Okay, so what about question 29? Yes, doctor?
Yes. Sentence duct to open which of the following location? Okay. A following a mouth beside the frontal tongue, opposite of the second molar tooth, opposite of the lower second molar tooth, lateral side of the chin, and none of the above. I think Okay. I think it's a upper side to upper second molar.
Yeah, excellent. Very
Hmm.
excellent. That is opposite the second upper molar. That is the opposite the second maxillary molar tooth. That's where Stinson's ducts open. Stinson's duct is the parotid duct, right? Wharton's duct is the submandibular duct. It's called Wharton's duct. So I'm just going to tell you a few stuff, okay? So Stinson duct. This is parotid, right? Wharton duct. This is submandibular, okay? And duct of Rividus or Rividus duct. What's that? Any idea? Anyone? Rividus ducts? Rividus or Revidus, whichever is more convenient. This is the ducts of the sublingual, right? Sublingual gland ducts are called ducts of Rividus. What about the major pancreatic duct? What's that called? Yeah, any idea? Anyone? Major pancreatic duct, what's that called?
Washing's duct.
Come again, please.
Duct of Washing.
Excellent. Yeah, duct of Versang or Versang duct. And the minor pancreatic duct, that's called
Duct of Santorini.
duct of Santorini. Very excellent. Duct of Santorini. Okay. So what about the next question? Yes? Question 30.
Yes. Following a difficulty tooth extraction, 20 years old man developed numbness of the lower lip, and the chin. Which nerve is damaged? I think it's the inferior alveolar nerve.
Yeah, so there is numbness of gums and lower lip and lower chin, the inferior alveolar nerve, a branch of the posterior division of submandibular nerve. Right, it supplies all of the mandibular teeth and all of the gum, mandibular gum, and the chin and the both skin and mucosa surface. So if in the exam they say the area was involving also the teeth or gum, then that's inferior alveolar. The mental nerve, in fact, it's a terminal branch of the inferior alveolar. The inferior alveolar terminates by giving off two branches, the incisive nerve, which supplies the incisor teeth, and the mental nerve, which emerges from the mental foramen and supplies the chin and lip. Is that right? Okay. Yeah. What about the next question?
Yes. 23 years old man undergo orchiectomy. The right testicular vein is ligated into the structure that's drain. So right test drain into the IVC. The left one
Yeah.
is renal.
Yeah. So the right drains into IVC, the left drains into. Okay. I have a funny question that came in January exam. Okay. January, by the way, it was a horrible exam. Really, it was very difficult. So the question was that there is laparoscopic procedure, not specified exactly what, but there is laparoscopic procedure. And basically it was on something in the retroperitoneal area. And yeah, I think it was right nephrectomy. Yeah, I think it's right nephrectomy. But after the or during the intraoperatively, right, there is a sudden attack of hypertension. There is sudden hypertensive episode. So the involved structure or the cause of this structure is related to the inferior vena cava in what way? Do you get that question, guys? What?
Please
And
try
you're
again.
going what? Okay, let me repeat. No problem, Dr. Rimaz. Let me repeat. someone undergoing right nephrectomy. Intraoperatively, there is hypertension. Okay, so they said the cause of hypertension is due to manipulation of a structure in the retroperitoneal region. This structure is related to inferior vena cava in what way? How it is related? So the cause of that hypertension, yeah, so basically Dr. Koro, they correctly said, they are asking about the relation of the right adrenal gland to the inferior vena cava in an indirect way. In an indirect way, they are asking about it. So what would be the answer? How the right adrenal gland is related to the IVC? In what way? Laterally, and laterally was not in the options. No, lateral was not in the options. So it is actually the superior pole is posterior to the IVC, right? So this is IVC, simplified diagram. And this is the right adrenal. The upper pole of the right adrenal gland is actually behind the IVC. It's just behind the IVC. So yes, it's posterolateral, but posteriorly the upper lobe is posterior. And that was the correct answer in the exam. Okay. Okay, anyway, let's progress. Yeah. Next one.
Okay. During modified radiotastectomy, which of the following structures are not removed? A. Entire breast. B. Nipple and areola. C. Pectoralis fascia. D. Pectoralis major. E. Following axillary lymph node. Okay. Radiography 2008. I'm not sure, but I think نبر عن رياضة بكتيريس فاشيا بكتيريس I think بكتيريس fascia or muscle.
Okay, let me tell you a funny story. There was a guy goes by the name Hallstedt. I think he was involved in mafia in one way or another. He was a very aggressive dude. He was a very aggressive individual. Okay, he's a surgeon too, and he goes by the name Hallstedt. Just imagine Hallstedt is in the mafia place, coffee shop, okay, talking to other mafia surgeons. And one of the surgeons said, I really hate breast cancer. We really need to get rid of breast cancer. So Hallstedt said, no problem. We'll just remove the breast. We'll remove pectoralis major. We'll remove most of axillary lymph nodes. I think if he wasn't, drunk or something, he would have said, let's remove the ribs as well. So it was a very aggressive intervention, and that was called Hallstedt mastectomy. Now, there was the bartender was you can say he's kind of on the softer side, he's a surgeon too, but he's on the softer side. He goes by the name Patty. Okay, even his name is a little bit soft. Patty. Patty said, you're an aggressive man, and you are a very violent man. How would you remove someone's pectoralis major and leave them basically disfigured? I think we just should leave the pectoralis major and do level 1 axillary dissection. So remove the breast down to the pectoralis fascia, but we will not do something more than that. Okay, so that was the modification of the original Hallstedt called Patty mastectomy. And then someone with a very softed heart, Italian. Italian people are very elegant, That Italian dude, I think is from Rome or something, he said, we will do quartz therapy, What's quartz? Quartz, which is quadrantectomy plus radiotherapy. So actually this stands for quadrantectomy, meaning removal of a quadrant of the breast plus radiotherapy. And that was one of the earliest forms, you can say, of conserving breast therapy. You know, conserving breast therapy, which means removal of the tumor itself with 1 centimeter margin only, you know. Then local radiotherapy is always there. Local radiotherapy to the chest is always there. If you don't do local radiotherapy following breast conserving surgery, that is going to lead to an unacceptably very high level of recurrence, okay? So what is breast conserving therapy? It is breast conservation surgery, which is removal of the tumor plus 1 centimeter safety margin, plus radiotherapy to the breast. So you can imagine that it really progressed from something very extensive and invasive, Hallstead, to something less and less over time. Now, of course, patty mastectomy is still practiced up to our day. So there are indications for that. Indications for breast conserving surgery, and there are indications for patty mastectomy. So what do you think? What are the indications for patty mastectomy? So suppose you have a woman, she's now in your clinic and she say you've diagnosed her definitely with breast cancer. You're now contemplating the treatment plan with her. And she's telling you that she would not like the breast be removed. She wants breast conservation surgery. When will you tell her no, that cannot be done? That's the question. Sorry. So Dr. Rimas said central tumor. Yes, that's one thing. That's something, yeah. So if the tumor is central, subareolar, the tumor size more than 5 centimeters is not something definitive, but actually in relation to the breast size, right? So if the tumor is big relative to the breast, then that's something we cannot do. What else? Yeah, what else? If there is a contraindication to radiotherapy, right? Because as I told you, breast conserving therapy must have radiotherapy. It must have. Like what? Like someone with SLE, systemic lupus erythematosus, someone with rheumatoid arthritis. They have weird reaction to radiotherapy. You cannot give them that treatment. Severe orthopnea is a relative contraindication. Multicentric, yeah, multicentricity. That's correct. So Dr. Hanan said multicentricity. Excellent, Dr. Hanan. That is multicentricity, patient preference. These are all contraindications, you can say, why they're absolute relative to breast conserving therapy. Good. Okay. So it will not, of course, modified radical mastectomy patty will not involve removal of pectoralis major muscle, definitely. Okay. What about the next question? Let's go to this one.
Yes. The medial umbilical ligament through the intrauterine life used to carry which of the following? I think is oxygenated blood from fetus to placenta. The oxygenated blood from the placenta to fetus, yeah. Umbilical vein.
So,
D.
what was your answer again, please? Which option?
Yeah, D. Oxygenated blood from placenta to fetus.
Option C, oxygenated blood from the fetus to the placenta.
D. Yeah, I think
D.
because they ask because okay, medial umbilical ligament. Okay, during intrauterine life to carry. Okay, sorry. They are right. They carry the oxygenated blood. Yeah, I mean by the letter
Yeah.
one.
Yeah, excellent.
Sorry.
So, actually, that's correctly said. That is, this structure is referring to the umbilical arteries, right? They're referring to the umbilical arteries. What is the median umbilical ligament? What's that?
Yeah, medial umbilical. I think medial umbilical ligament is a remnant for the medial umbilical vein.
Okay, so my first question is, what is median with an N? And what is medial with an L? And what is lateral? And you need to be very clear with these things. Median, medial, lateral. Excellent. So median, N with an N, is a remnant of the urachus,
Yeah.
which connects the, what is that? The Yolk sac to the urinary bladder.
Upper
That is the
part.
umbilical vein to the urinary bladder. So median is, which is exactly in the middle, that is called urachus. Medial is the umbilical arteries.
Artery.
And lateral is not a true ligament. It is just in a elevation of the peritoneum, caused or imparted by the presence of the inferior epigastric artery and vein. Okay, so what is the adult remnant of the umbilical vein? We didn't mention the umbilical vein here. The adult remnant of the umbilical vein is what?
I think it's a falciform ligament teres.
Not the falciform ligament.
Ligament
It's not that.
teres.
Yes, Dr. Corset, ligamentum teres. Excellent. Yeah, it's ligamentum teres, or round ligament of the liver. That is the actual remnant of the umbilical vein. What is the origin of the, you said falciform ligament. What is the origin of the falciform ligament? It's a derivative of what? I will show you a simple thing. I will show you a simple thing that will answer so many questions that you encounter in the exam. Okay? I like simplicity. I love to be very simple about things. So imagine that this is the tube, which is the gut tube. And this is the gastric dilatation. Without detail, I don't like detail, rotation, whatever. No, just keep things simple. This is the wall, the anterior body wall, and this is the posterior body wall. So the vertebrae, okay? So it means this is the retroperitoneal region. There is, this tube is hanged by two mesentery, you can say. It is hanged in place by two mesentery. One anterior, which is called ventral mesentery, and one posterior, which is called dorsal mesentery. Very simple, right? Dorsal ventral mesentery. The spleen will form in the dorsal mesentery. Here's the spleen, okay? The spleen will form here in the dorsal mesentery as mesenchymal condensations. Remember, that's not from the foregut tube. These are mesenchyme, okay? That's a common question in the exam. It will, the presence of course, the spleen doesn't appear as one chunk like in the diagram. It actually appears as small chunks, and then they fuse, and then they make the big spleen, right? So if there's failure of fusion, there's something called polysplenia. Polysplenia. If it doesn't come it doesn't originate in the beginning, that's called asplenia, congenital asplenia. But anyway, that's not our discussion. So it actually, when it is here, it will divide the dorsal mesogastrium into two parts. One in front here, is that right? Let me highlight that better. One in front here, and that is going to give the short gastric, the splenogastric ligament, which houses the short gastric vessels. Is that right? And one behind, which will form the leno-renal ligament, which is between the spleen and the left kidney. Now the liver, on the other hand, the liver grows from the duodenum as the hepatobiliary bud. So it's actually originating from the duodenum here as something called hepatobiliary bud. And it is thus from the foregut tube. It's not from the mesenchyme. So that's the liver will grow like this from the duodenum, from the foregut tube, and it will divide the ventral mesogastrium into two parts. Part behind here, which will form the lesser mesentery, right between the stomach and the liver, the lesser mesentery. And one here, right, let me use another funny color here, which is what? The falciform ligament. So the falciform ligament is coming from the ventral mesentery. For ease of memory, the ventral mesentery give rise to the lesser omentum, right? Lesser omentum and the falciform ligament. The rest is coming from the dorsal mesentery. Everything else, all of the other ligaments that you know are coming from dorsal mesentery. Now, okay. Let's take one more question and take a quick break. Yes. Yeah. Let's see this one.
Okay. After a difficult breech delivery in unit developed herpes palsy, which of the following nerve is least likely affected? Okay, musculoskeletal nerve, axillary nerve, radial nerve, suprascapular nerve, and nerve of clevius. Okay, herpes palsy strong, so I will go. There is no option in Allah. Okay. I will go supraspinatus. Why?
Okay. Do you mean option D?
No.
Okay. Let me ask you, what is herpes palsy?
Yeah. So I think herpes palsy is a problem about it's a brachial plexus injury in the upper trunk. I think C5 until C6.
Yeah. So C5 and C6. There's a problem there.
Yes.
So C5 and C6 come together and form the superior trunk. Superior trunk gives two branches. Is that right? It gives the suprascapular nerve and nerve to subclavius. So definitely D and E will be affected. Do we agree on this? They will be
Yes.
affected. Okay. What about axillary nerve? What's the root value of axillary nerve?
C7.
C5, C6.
It's a posterior cord. Axillary and radial.
Yeah, so it is C5, C6, is that right? So definitely this is going to be affected. So if excluded B, that's going to be affected. D, it's going to be affected. E is going to be affected. So we're left with option A and C. Is that right? What do you think?
Yes. Okay.
Musculocutaneous, what's the
No,
value of
I think yeah. I don't see radial because radial is same as I think axillary because it's in
Okay, so musculocutaneous nerve, let's follow. So that's C5. Oh my God, let me go to the next screen better. Okay, that's much better. So focus with me. C5, C6, C7, C8, T1. C5 and C6 will join to form superior trunk. C7 continuous middle trunk. C8 and most of T1 will come to form the inferior trunk. Then each trunk will give a division, right? So every trunk will divide into anterior and posterior division. All of the posterior divisions will come together to form the posterior cord. The anterior division of C5 and C6 will come together to form the lateral cord. And the anterior division of the lower trunk will continue on its own as the medial cord. Again, let me repeat. So the posterior cord contains all of the posterior divisions from all the trunks. So it contains branches from C5 down to T1, all of them is contained within the posterior cord. The lateral cord, which will give rise to the musculocutaneous nerve in the end, is containing fibers from, let's follow the map, from C5 and from C6, definitely, and from C7 through the anterior division of through the anterior division of the middle trunk, that is, of C7. So definitely, musculocutaneous nerve is going to be heavily affected because branches or supply from C5 and C6 will be lost. The radial nerve contains branches from all of the roots of the brachial plexus, but it will be less affected compared to the musculocutaneous. Is that right?
Yeah.
Everyone is clear on the answer? No problem? The answer is radial nerve. Do you agree with me?
Yes. Okay.
Okay. Okay, let's take one more question and then we'll take a break, okay? Let's see this one. 35.
Which of the following reflex is used to confirm brain death? Okay. Absence of angle reflex. Okay, is used to confirm. Absence of angle reflex. Absence of web reflex. Absence of oculocephalic reflex. Absence of knee shark reflex. Absence of respiratory effort on induced hypoxia. So to confirm this, right? Okay, no, again, no. I think it's E.
There is absent respiratory effort on induced hypoxia. Okay, what if this someone is on opiate intoxication? What if they have a neuromuscular disease like Guillain-Barré? They will not have respiratory effort even when they're hypoxic. Is that right?
Okay.
I remember one of the OSCE stations in the communication skill, okay? They are asking about a brainstem death. Okay, so actually they will tell you someone's daughter is in ICU, okay? And she have had spontaneous arachnoid hemorrhage. She's not recovering. And she's announced brainstem dead by 2 different consultants on 2 different occasions. Please inform the father of this news and discuss organ donation with the father. It's a nasty station, right? Because you have to break bad news, basically telling the father that your daughter died, basically, because brainstem death equates to death of the person. And then you have to tell them that we would like to take organs also. It can be very sensitive, a very sensitive situation. Is that right? Anyway, so in the station, the examiner commonly asks how to confirm brainstem death. How to confirm it? Number 1, you should exclude all causes of reversible coma. All of those metabolic and pathologic and whatever causes of coma, like someone that is on opiate intoxication, someone with hypoxia, someone with hypothermia, someone with hypothyroidism, someone on alcohol intoxication or benzodiazepine overdose. All of those reversible causes must have been excluded. That's number 1. Before you even start brainstem death testing. That's one of the criteria. The second criteria is that they have to have an evidence of an irreversible brain lesion. On CT or MRI or on other imaging techniques, there is evidence of a pathology, like massive brainstem stroke, for example, or diffuse axonal injury, or whatever, severe lesion, brainstem hemorrhage, that is irreversible. It is not treatable. Then, if the patient meets these criteria, you should go on for brainstem death testing. Brainstem death testing includes basically 2 main things. Number 1, absent brainstem reflexes. Absent brainstem reflexes. Number 2, apnea. Okay, apnea that is on removing. Of course, you have to pre-oxygenate the patient first to prevent hypoxia. You don't test hypoxia. That's an important thing. Do you see here in the option, absent respiratory effort on induced hypoxia? No, you do not induce hypoxia. You actually pre-oxygenate the patient with 100% oxygen to prevent hypoxia. You're actually removing them off of the ventilator to build up hypercapnia. You're testing the brainstem response to hypercapnia, not hypoxia. Is that right? That's very important. Okay. So brainstem death testing, so option E is excluded because we are not inducing hypoxia. So oculocephalic reflex is one of the brainstem reflexes. Oculocephalic reflex is one of the brainstem reflexes. So that's why this is the answer, right? Absolute oculocephalic reflex. Are we clear on this? No problem? No problema?
Yes.
Great. Okay. So let's take a break, grab some coffee, breathe some fresh air, and then we'll come back and continue, right? So see you in about like 10 minutes, 15 minutes, okay? See you in 15 minutes, everyone. Thank you. I think we stopped at question 36, is that right? So if anyone else want to participate in reading the questions, kindly just say it in the chat or raise the hand. Yeah. Anyone, please? Yeah, just raise the hand if you would like to read the questions with me. Help me along. I'd appreciate that. I'm sorry. Yeah. Anyone, please feel free, don't shy out. Anyone. Yes, please.
Hello?
Yes, Dr. Koro. Yeah. How are you doing? Long time
Yeah,
no see.
I'm fine, sir.
How's the studies going? Hope they are doing fine.
I'm trying my best.
Yeah, I think you're doing great. You're doing very great. I'm seeing your progress in the website and everything. It's amazing. You're doing a wonderful job. Okay.
Thank you, sir.
Yes, let's go with question 36.
Okay. During an operation at the posterior triangle of the neck, a nerve is damaged. The muscle affected exerts which of the following actions? A. External rotation of the shoulder, protraction of the scapula, extension of head, flexion of head, none of the above. Well, this muscle, I think the answer is common. Weird extension. I think the muscle affected here is the trapezius muscle.
Yeah, that's correct.
But
The one that is
the nerve to sternocleidomastoid is given off before it enters into the posterior triangle.
yeah, that's correct also, yes.
So I'm not sure if I would external rotation of the shoulder. I think none of the above.
Okay.
Because
Okay.
trapezius is like elevation of the shoulder.
Yeah. So the actions of the trapezius is a bit of a complex muscle. So it has superior fibers, which elevates the shoulder, shrugs the shoulder, right? And then there is middle fibers, which retract the scapula, not protract, retract, meaning brings it closer to the spine. And the lower
Yeah.
fibers depress the shoulder. And if they act all together, they can rotate the scapula onto or upon the chest. But actually, the two trapezius muscles from either side, they are attached to the superior nuchal line and the external occipital protuberance in the skull and the occipit bone. If they contract simultaneously, they can actually
Extend the head.
yeah, they can actually extend the head, right? So it is a very tedious question, I can say. It's a difficult one. So actually, extension of the head, it's one of the minor actions of the trapezius muscle, but it's there and it's described in everything, right? If both of them contract simultaneously, they can extend the neck. There is extension of the head. Okay. Okay, let's see the next question.
Following road traffic accident, a 39-year-old male is unable to abduct the shoulder beyond 90 degrees. Which of the following muscles would show reduced function? From 0 to 15 is the supraspinatus. From 15 to 90 is deltoid. From 90 upwards is serratus anterior and the trapezius muscle. So the answer here is D.
Excellent. Yeah, so it is as you said, very nice. It is serratus anterior. Okay, let's jump to the next one.
Which of the following muscles originates from the posterior surface of the scapula? From the posterior surface of the scapula at the inferior angle. The answer here is the teres major.
Yeah, so that's correct also. Teres major originate from this tiny area at the inferior angle, the oval-shaped area at the inferior angle of the scapula. And then it inserts into the medial lip of the intertubercular groove. And it does what thing? What's the action of teres major?
Teres major, it adducts the humerus, it adducts the arm.
Adduct, okay, that's one action. That's true. It adducts the arm and internal rotation. Excellent, Dr. Nouri said. Internal rotation and slight extension also, because imagine it in a 3D way. It's coming from the scapula, moving anteriorly in front of the humerus, and then attaching to the medial lip of the intertubercular cycle. So if it shortens, it will internally rotate, adduct and extend. All of these are actions. Sorry again. Teres major. Okay. Let's go to the next one. Question 39.
A 6-month-old child is brought by his anxious mother complaining of excessive vomiting. The child gains weight and feeds normally on formula milk. He is not breastfed. Chemical investigations reveal the following: sodium 140, that's normal. Potassium 4, that's normal. Chloride 101, that's normal. Calcium 2.3. Calcium 2.3, I think it's normal. Can't
Okay.
remember. Which of the following is the most likely underlying diagnosis? Gastroesophageal reflux, hypertrophic pyloric stenosis, pyloric atresia, duodenal web, intussussection. Okay, excessive vomiting, child gains weight and feeds normally on formula milk. Okay, so in this case, a child gains weight and feeds on formula milk. I think I would go with excessive vomiting. I'll go with B.
Hypertrophic pyloric stenosis. But in
Yes.
hypertrophic pyloric stenosis, the child would lose weight, would have hyponatremia, would have hypokalemia also, hypochloremia. There would be some kind of arrangement. But if everything else is normal, it means...
Okay, so I'll go with A.
Yeah, so it is A, physiological reflux, physiological gastroesophageal reflux. Actually, in this age, the reflux is very common, especially when they are fed on formula. Formula is especially a risk factor because it delays gastric emptying, it kind of creates a milk clot. It's not like the natural breast milk. So formula milk is one of the key things that are mentioned in the case because that's definitely a risk factor. the mother, of course, reflux is not vomiting. Reflux, it is not vomiting. But the history is coming from the mother. So to her, she will say he's vomiting. She will never say he's having reflux. This is not the way that you can say people in the population speak normally. When they just regurgitate some of the milk, they will say the kid is vomiting, right? They will not say he's having reflux. So vomiting is an active reflex. It's a coordinated reflex. There is reverse peristalsis, there is contraction of the pylorus and relaxation of the lower esophageal sphincter, contraction of the abdominal wall muscles. It's a coordinated neural reflex, but reflux is effortless. It is not a reflex. Okay, reflux is not a reflex. It's something effortless. So as long as the baby is gaining weight, progressing normally, does not have any electrolyte problems or abnormalities, everything is going by the book, no need for definitive treatment of the reflux. This is just called physiological gastroesophageal reflux, which is something all kids have, all children have. But when it becomes complicated, like if there is cough, aspiration pneumonia, dental caries, esophagitis, bleeding, peptic esophagitis, in that case, we will call it gastroesophageal reflux disease, because it has become a disease, actually, not something physiological. But in this case, everything is going correctly by the book, no problem with this kid. So it just reflux. Okay. What? By the way, anyone, you can stop me at any moment. If you have a problem with any question, just stop me or raise hand, or I will be more than happy to explain. Yeah, I'm sorry, Dr. Corey. Yes? Question 40?
Okay. Following a road traffic accident, a 30-year-old man has bilateral tibia and fibula fractures. His left limb is swollen with painful loss of pulses. From the following options, choose the most useful test clinically. Bring the foot passively into dorsiflexion, hallux flexion, hallux extension, toes plantar flexion, inversion. This is a case of compartment syndrome,
Yeah.
and I think it's passive stretching of the great toe. So I would go with option C.
Hallux extension. Okay. Okay. Good. Okay. Let me say something about compartment syndrome in the leg. I have a question. Okay.
Flexion is downwards. Extension is upwards. I think it's flexion. It's flexion. Hallux flexion.
Yeah, it's hallux flexion. The answer correct. It's hallux flexion. But not.
Yeah.
But why? Right. The important thing to understand is why. Why hallux flexion? What in the leg? What is the most commonly involved compartment?
The anterior compartment.
The anterior, nice. The anterior compartment, anterior tibial compartment, which has what? It has tibialis anterior, it has extensor hallucis longus, and extensor digitorum, and peroneus tertius also. Okay, so these are the muscles that are there. So if you want to create or elicit pain in a particular compartment in the leg, you have to stretch the muscle of that compartment. These are anterior compartment muscles, right? So you have to stretch these muscles in one way or another to create pain or elicit pain in that compartment. So it's actually stretching. So in that case, if we want to elicit pain in that case, so we will go with what? Yeah, hallux. What's the option? Hallux flexion. There is plantar flexion, right? Hallux plantar flexion to stretch that muscle and create pain. Do you agree with me?
Yes, sir.
Dr. Azza, sure. I'll be more than happy to explain. Let me just go quickly to the board. Okay. I will draw a very simplified diagram. Okay, a very simplified diagram. This is the foot. Okay, and this is the leg. Is that right? And this is the bone. This is the bone. Suppose that's tibia. Okay. And that is what is this? This is anterior compartment. One of the muscles in the anterior compartment is called extensor hallucis longus, which, let me show you the muscle. Okay, extensor hallucis longus. It's one of the muscles in the anterior compartment, right? That's the muscle, suppose. And that's the tendon of the muscle. Okay, and it inserts onto the big toe. Suppose this is the big toe, it inserts here. So the most common compartment involved in the leg is the anterior tibial compartment, in which this muscle is located. So clinically, to elicit pain, you have to stretch the muscle of that compartment. This is the basic rule, meaning you have to do the action opposing to that muscle to stretch it. So the extensor hallucis longus extends the big toe in this direction. Extension, or that is dorsiflexion, it's the same. Is that right? So if you passively flex the big toe, passive flexion of the big toe, it will stretch the muscle and cause pain. So this is one of the standard tests in patients suspected of compartment syndrome. So in compartment syndrome, if you have someone with suspected compartment syndrome, what is the first? What is the isn't the flexor group? Yeah, the flexor group is in the posterior compartment. But if you passively, with your hand, if you flex the big toe, you are stretching the muscle in the anterior compartment. You are stretching it and causing pain. Is that right? So what I would like to say, what I would like to ask is that in case of suspected compartment syndrome, you have now a patient with suspected compartment syndrome. What is the first thing to do? What is the suppose he's post-operative, right? Post-operative patient for, let's say, intramedullary nail insertion, tibia. What is the next step now in this patient? Patient complaining of pain, screaming. You're thinking that he may have compartment syndrome. Yeah. The first thing is to remove any casts or slabs, even slab or bandages. Remove any constriction off of the limb. Limb elevation. Wait a minute, guys. Just give me a second. Sorry about that. Just, I'll come back in just 1 minute. Hang on. I will come in 1 minute. Okay. I'm sorry. Let's come back. Let's come back. So what is the next step after that? So you basically removed any constriction, right? You removed any constriction, limb elevation. What's the next step? Okay, fasciotomy is the standard treatment. For compartment fasciotomy through lateral incision is a standard treatment. But not all of the time you should jump for fasciotomy immediately. Yeah, excellent, Dr. Hanan. You have to measure the compartmental pressure, which is a procedure that doesn't take even 1 minute. a needle is inserted beyond the fascia into the suspected compartment. It will definitely confirm that is refute compartment syndrome, because there's a lot of differentials there. This can be DVT, this can be cellulitis, this can be necrotizing fasciitis, this can be infected implant if there's orthopedic implant. There can be ruptured Baker's cyst. It can be a lot of differentials that give, or acute limb ischemia. Another thing is acute limb ischemia. So there's a lot of differentials for unilateral acute leg pain. Even prolapsed disc can cause acute leg pain. So you have to confirm before going for fasciotomy. Always keep in mind that fasciotomy is not a walk in the park. It is not a simple operation, and it entails a lot of complications, including nerve damage, arterial damage, wound infection. So you don't jump immediately on the fasciotomy. You have to confirm the diagnosis first, preferably, right? So in the guideline, Best Medical Practice, or BMG, British Medical Journal, they say what? They say when you are suspecting compartment syndrome, you should measure compartment pressure prior to fasciotomy. You should consider measuring compartmental pressure prior to fasciotomy. So they said suspecting. You are suspecting it in almost any case. You can almost always, you cannot confirm it 100% clinically. There will always be some suspicion. So when they said suspected case, meaning almost all cases, you should go for compartmental pressure. Okay, so you did compartment pressure. What is the cutoff for fasciotomy? When will fasciotomy be indicated? Beyond which reading, right? That's the question. Yeah.
More than 30 millimeters of mercury.
Excellent. That is more than 30 millimeters of mercury. More than 30. If it's more than 30, that's definitely indication for fasciotomy. Cool. Okay. Let's go to next question, 42. Yes,
Which of
please,
the
Dr.
Should I continue with that?
Yeah.
Which of the following dural venous sinuses is located at the inferior limit of the falx cerebri? It's the inferior sagittal sinus.
Excellent. That is inferior sagittal sinus. Okay. What is the dural venous sinus that is located where the tentorium cerebelli meets the occiput? When the tentorium cerebelli meets the occipital bone, not in the midline, laterally, what is the dural venous sinus at this location? That was a question in one of the recent exams.
Come again, sir.
Yeah, the question is, what is the dural venous sinus that is located at the junction of the tentorium cerebelli with the occipital bone? Yeah.
Tentorium cerebelli with the occipital bone. Isn't that the confluence of the sinuses?
Yeah, so the confluence of the sinuses as well as the transverse sinus, right? The transverse. All of you have to be very clear on this, because this is a very common question. Okay, let me draw something funny. Would you allow me that? You know, my drawing skill is not that perfect, but let me try. Okay, suppose this is the skull. Okay, here is the beautiful eyes of a beautiful person. Mascara too, you know, everything there. And here's the anterior cranial fossa. And yes, what is that? This is the petrous bone, foramen magnum. And this is the sella turcica, and the pituitary gland is here. Right, and also cribriform plate of the ethmoid bone. Claro. So, of course, we've already established that there is a dural venous partition that is extending like this. Is that right? This is called folks, right? This is the folks. Let me highlight the folks. All of that is folks cerebri, right? And in that folks cerebri, the superior limit, what's here? What's in the superior limit? Yeah.
The superior sagittal sinus.
Superior sagittal sinus. And the inferior limit, like in this question, here, the inferior sagittal sinus. Okay. Of course, the folks comes back and merges with the tentorium, right? The tentorium cerebelli, which is here. Tentorium cerebelli is attached to the occiput, right? And it's attached to the petrous apex. It's attached to the petrous apex here. That's one attachment, petrous apex and the occiput. And of course, from the other side as well, right? From the other side as well. Okay, so that's the other side. This is the petrous apex from the other side. And of course, it's anteriorly hooked to the anterior clinoid processes. And there's an opening here called the incisora, through which the midbrain passes. Okay, that's the tentorium cerebelli. It divides the cranium into supratentorial and infratentorial compartments. Is that right? So, the inferior sagittal sinus, now look carefully, the inferior sagittal sinus moves in the inferior limit of the folks and then fuse with the vein of Galen here, the great cerebral vein of Galen, to form, what is that? What's that? What's this?
To form the straight sinus.
Straight sinus. So that can be a question on its own. The straight sinus is located where? It's located at the junction of the folks with the tentorium, right? The junction of the folks cerebri with the tentorium cerebelli. That's the location of the straight sinus. And that is our other friend, the superior sagittal sinus. Superior sagittal sinus moves back until it meets this sinus, which is called confluence of sinuses, which is also where the straight sinus drains. So the straight sinus and the superior sagittal sinus drains into the confluence of sinuses. I have a question. This, of course, from the confluence of sinuses, there are two sinuses which are originating, which are the transverse sinuses. Two sinuses originating and moving laterally from the confluence of sinuses. I have a question. Wait, okay, so this is going to be the right transverse sinus, and this is the left transverse sinus. Okay, so the straight sinus drains exactly where? Right or left transverse sinus, or both? Where does it drain mostly? Is it draining mostly to the right or draining mostly to the left?
It drains mostly to the left. It bends leftwards.
Excellent, yeah. So it bends leftwards and drains mostly to the left. Okay, that's great. Whereas the superior sagittal sinus, when it meets the confluence of sinus, it bends rightwards and drains mostly to the right. That's very important. Now, of course, the continuation of the transverse sinus is called sigmoid sinus. What is the distinction? What is the anatomical boundary? Where's the line where I can say this is transverse and this is sigmoid? Like, at which landmark? Yeah? Any idea?
It's around the inner surface of the mastoid part of the petrous bone.
It's very close. So actually, when the transverse sinus leaves the surface of the occiput, as soon as leaves the surface of the occiput, now it's called sigmoid, right? So once the transverse sinus, in other words, reaches the surface of the petrous bone, it will be called transverse. Now I have a question. It will be called sigmoid, sorry. Now I have a question. Which sinus is located at the junction of the tentorium cerebelli with the petrous apex here? Here and here. So of course the tentorium attaches to the petrous apex. Which sinus is located at this junction? Tentorium with petrous apex. Yeah. It can be a question, isn't that? It can be a question. That's called superior petrosal.
Yeah.
Right, superior petrosal sinus. The inferior petrosal sinus is between the clivus and the petrous bone, down below. What is the sinus that is located on either sides of the cilia turcica? Yeah, famous one, that's one.
Yeah, cavernous sinus.
Cavernous sinus. What is the sinus that is located under the lesser wing of the sphenoid and draining to the cavernous sinus? There's a sinus here. This is lesser wing of sphenoid, right? This is lesser wing of sphenoid. There's a sinus just under it, and it is moving posteriorly and then draining into the cavernous. Excellent. Sphenoparietal. Excellent phrase. This is called sphenoparietal sinus. Sphenoparietal sinus. You know that the falx cerebelli, you know that? Not falx cerebri, falx cerebelli, with a double L. What is the sinus located? At the junction of the falx cerebelli with the occiput. You know? The falx cerebelli is just under the tentorium. You have to draw another diagram. Now suppose I'm sitting here, right? I'm sitting in the cilia turcica, and I'm looking down here, right? That will be the diagram like this, you know? And this is the foramen magnum, and this is a crest called internal occipital crest. Here's the confluence of sinuses, and here are the transverse sinuses. Is that right? There's a sinus here. There's a sinus here. Excellent. This is called occipital sinus. Occipital sinus, which communicates with the venous plexus of the spine down below, and above it drains through the confluence of sinuses. I just wanted you to all be very clear on these things because they are commonly asked about. No questions about this? No questions? Claro? Okay. Fine. Now let's come back. Let's come back. Yeah, this one. Yeah, so question 43, yes?
The transverse dural sinus is located at which of the following? Junction of the falx cerebri and tentorium cerebelli, junction of tentorium cerebelli and petrous apex, junction of tentorium cerebelli and occipital bone, junction of falx cerebelli and tentorium cerebelli, none of the above. Okay, it's at the junction of the falx cerebri and tentorium cerebelli. So that's A.
No, really? I don't think so, right? I'm a bit sick, maybe I'm confused. Junction of falx cerebri and tentorium cerebelli, this is straight sinus. Right?
Okay. Then it's B. It's B.
Junction of tentorium cerebelli and petrous apex, this is superior petrosal. Transverse sinus, which is the junction of the tentorium cerebelli and the occipit, right? From the previous diagram. Let me come back. Here. This is tentorium cerebelli, junction of tentorium cerebelli with the occipit. This is transverse sinus, right?
Yes, correct.
Okay, good. Okay. Yeah, let's come back. So the answer to this is going to then be option C. Option C. Right? Junction of tentorium cerebelli and occipital bone. Okay, let's continue. Question 44. Yes.
Which of the following is true about the inguinal ligament? Attached to the anterior inferior iliac spine, forms the roof of the inguinal ligament, forms the superior border of the femoral triangle, attaches to the pubic symphysis, deep to the femoral nerve. True about the inguinal ligament. The inguinal ligament forms the superior border of the femoral triangle.
Yeah, so it forms the superior border of the femoral triangle. So the inguinal ligament is actually the inferior limit of the external occipital, external, what's that called? Oblique aponeurosis, right? So it's the inferior limit of the external oblique aponeurosis. That's called inguinal ligament. What is the name of the posterior reflection? What is the name of the posterior reflection of the external occipital aponeurosis at the level of the inguinal ligament that you commonly see every day on laparoscopic hernia repair? It's one of the important landmarks that on laparoscopic repair, when you see that structure, you say, this is inguinal ligament. You know, it is a marker of the inguinal ligament from inside. What's that called? Anyone have an idea about this? Yes, Dr. Naji, you raised your hand. Yeah. Sorry, Dr. Jalil Yusuf. Yeah. You have a question?
No.
No question. Okay. So what, any idea about this? Pectineal ligament. No, not pectineal ligament. Conjoint. No. I mean, laparoscopically, when you are going, you must have seen it. If you have done laparoscopic hernia repair, you must have seen that. It is very clear a marker of inguinal ligaments from inside. What's the posterior surface of the inguinal ligament? That's called what? Iliopubic tract, right? Iliopubic tract. Iliopubic tract. So what is iliopubic tract? Iliopubic tract is the simply posterior surface of the inguinal ligament, or the posterior reflection of the external oblique aponeurosis. It's the same thing. Iliopubic tract. Anyway, let's see the next question. Question 45.
During laparoscopic inguinal hernia repair, the hernia sac was found to protrude from the posterior wall of the inguinal canal immediately medial to a vessel. This vessel originates from which of the following? Internal iliac, femoral, external iliac, aorta, and iliolumbar artery. Okay, so the hernia sac protrudes from the posterior wall of the inguinal canal immediately medial. So if it is medial to the the vessel is the inferior epigastric vessel. If it's medial
Yeah,
to it, that is a direct hernia. So the inferior epigastric vessel is a branch of the external iliac artery.
Excellent, yeah. So it's a branch of external iliac. That's correct. Okay, next question.
A 30-year-old pregnant female suddenly developed severe chest pain. Pulmonary embolism was suspected. Which of the following physiological alteration that occur? Okay, which of the following is a physiological alteration that occur in pulmonary embolism? Metabolic acidosis, low VQ ratio, high VQ ratio, reduced respiratory rate, bradycardia. So the answer to this question, ventilation perfusion ratio should go up. C,
Yeah. Yes,
because there
it will
will be
go.
more ventilation and reduced perfusion.
Yes, that's correct. Okay. Now I have a question. Okay, yes, so it is, if there's a pulmonary embolus blocking, means the ventilation relative to perfusion is high. That's correct. Okay, so suppose the options are different. Okay, I've seen that in one of the old exams. It didn't come back again, but just in case, okay? Now, same scenario, nothing different, but the options include metabolic acidosis is there, low VQ is there, okay? This is not there. Okay, this option is not in the options. Reduced respiratory rate is there and bradycardia is there. Okay, no. Yes, I remember. So this is option C. Option C is higher, increased ventilation. Sorry. My memory is terrible. Increased minute alveolar ventilation. This is not here. Decreased minute alveolar ventilation, and E is bradycardia. Yeah. So what do you think? What will be the answer in this different scenario?
The answer will be C, increased minute alveolar ventilation, because respiratory rate will go up.
Okay.
A minute ventilation is respiratory rate times tidal volume.
Yeah. Okay. What about the act of bronchoconstriction that happens in pulmonary? Let me tell you something. Let me tell you a funny thing. Okay, this is the lung, is that right? And here is the pulmonary artery feeding into the lung, and of course it goes into branches. Okay, suppose this branch supplies this area. Okay, and this branch supplies this area, and this branch supplies this area. Suppose an embolus is lodged here. Okay, what's going to happen? Perfusion to this area will reduce. So ventilation will go down, right? In this area. Perfusion will go down in this area, right? Q. Ventilation, perfusion. Q. The perfusion will go down, right? Okay. So when perfusion goes down, there's a physiological reflex. There's a physiological reflex which includes that the bronchus, which is leading to this area, undergoes bronchoconstriction. That's a reflex. This is why this happens, to divert air to better perfused areas in the lung.
Yeah.
Okay. It diverts air to a better perfused area in the lung to maintain the VQ. Now, similarly, let me show you another thing, okay? Another funny thing. This is the lung. This is the bronchus. Suppose someone inhales the foreign body. and it lodges in one of the lobar bronchi, you know what's going to happen? This area will not receive any air. All of those alveoli distal to the obstruction will not, if it's complete, it will not receive any air. Similarly, the blood vessel which is supplying this area will undergo there is vasoconstriction. This is called the hypoxic pulmonic vasoconstriction. Why? To divert blood to better ventilated areas, to maintain the VQ. All right? Okay? So, it works either ways. In case of an embolus, we don't want air to be wasted. We want the air to go to better perfused areas, not wasted. In case of a foreign body in the blocking the bronchus, we will constrict the blood vessel going to that alveoli dependent area so that blood is not wasted, so that blood goes to better aerated areas in the lung. So actually, the area which is affected, look carefully, the area which is affected, its ventilation will go down. Both ventilation and perfusion will go down, but perfusion will go down to a greater degree than ventilation, so eventually the VQ ratio will go up. But in fact, the ventilation is also reducing due to bronchoconstriction. The ventilation is also reducing. Okay? That's a funny concept. It is indeed a difficult question, but it's a funny concept. The ventilation is gonna go down as well as perfusion, but the drop in perfusion is much more. So overall, the ratio will be high VQ. Okay, that's the whole thing about it. But despite this, I'm still with Dr. Koro that the minute ventilation as a whole will go up because there is tachypnea. But however, I wanted you to know the real truth about it. If they say in that particular area of the lung that is involved with the embolism, the ventilation is going to go down. But totally the ventilation should ideally go slightly up. Is it clear or did I confuse you? The physiologic dead space will increase definitely because Dr. Rimas said the physiologic dead space will increase. Yes, it will increase. Yes, because eventually the air is coming in to a part which is not perfused. So it is dead space also, physiologic dead space. That's correct. Okay, so yeah. Let's see the next question.
Following a road traffic accident, a 27-year-old male patient complains of inability to evert the foot, with loss of sensation on the dorsum of the foot. The nerve affected has the root value of L4 to S1. That's the superficial peroneal nerve.
Yeah, so superficial peroneal nerve roots is L4 to S1, which is option A. You will see that in some textbooks, they tell you that superficial peroneal nerve is L4 to S2. Even in Google, in some of the websites, some websites will see writing L4 to S1, other websites writing L4 to S2, but according to Gray's Anatomy and according to the more respected textbooks or the established ones, it's L4 to S1. Okay, so we're gonna go definitely with them. Yeah, let's take a couple more questions and then I think that would be enough. Yes?
A 24-year-old primary gravid, first pregnancy, presents with sudden onset of chest tightness and shortness of breath. Her father died from a myocardial infarction at age of 50 years. Which of the following is the most likely underlying diagnosis? Aortic dissection, acute massive pulmonary embolism, myocardial infarction, pneumonia, pneumothorax. So this is a case of acute massive pulmonary embolism. It's
Acute
not
mass.
dissection because they didn't say the chest pain was tearing.
So actually, it's not tightness. Yeah,
Pregnancy
that's
is a
correct.
risk factor. Pregnancy is a risk factor for pulmonary embolism, a big risk factor.
Yeah, I agree with you. Also pregnancy is a risk factor for aortic dissection, but aortic dissection is a much less common condition, definitely, compared to acute pulmonary embolism. Everyone agrees about that. Okay, yes, correct. Yeah. What's the next question?
A 59-year-old female presents with chronic non-healing ulcer above the medial malleolus. Okay, associated with pigmentation and eczema. Okay, which of the following is the most beneficial treatment? This is characteristic of a venous ulcer: the pigmentation, eczema, the location of the ulcer, medial
I agree.
malleolus. So the most beneficial treatment for this patient would be compression stockings.
Yeah, so the
So we remove the venous
almost,
return.
yeah, that's the most established and most established treatment. So suppose you have someone that have venous ulcer, but their ABBI is also low, that they have arterial disease, mixed ulcer, venous as well as arterial. What are you going to do about that patient?
You treat the arterial ulcer first, then manage
Yeah,
the venous.
yeah, excellent. So treat the arterial ulcer first, treat the arterial insufficiency first. And in a lot of the times, when you treat the arterial problem with revascularization, either endovascular therapy or surgery, whichever the situation, and depending on the exact anatomy of the disease, many of the times the venous ulcer will also heal, right, without having to have further therapy. Okay, what's the next question?
A 41-year-old man presents with iron deficiency anemia. His father died from colorectal cancer at age 40. His aunt died from endometrial cancer at age 38. His sister developed endometrial cancer. Which of the following is the most likely diagnosis? Familial adenomatous polyposis, Lynch syndrome, Cowden syndrome, neurofibromatosis, Puigger's. I think this is Lynch syndrome. Lynch syndrome is usually associated with endometrial cancer
Yeah,
and
excellent.
colorectal cancer as well.
Yeah, Lynch syndrome. Lynch syndrome is associated with multiple malignancies in the women: endometrial cancer, pancreatic cancer, gastric cancer, hepatocellular cancer, many other forms, but the most common is colorectal cancer. Usually,
Yeah.
now this is very important note, patients that have Lynch syndrome, I, I want you to write this down, guys. Really, this is going to be in your exam, I'm sure. In Lynch syndrome,
Usually on the
majority,
right.
yeah, it's on the right, it's mucinous and associated with lymphocytic infiltration. And
Okay.
on histopathology, there is microsatellite instability. That's so important. Microsatellite instability, which is now a major criterion in the diagnosis of Lynch syndrome, that there is microsatellite instability in the sample, histological immunohistochemical examination of the sample. There is microsatellite instability. In familial, I have several questions about familial adenomatous polyposis because there's a lot of updates about it. First of all, what is the gene that is involved in familial adenomatous polyposis and where it is? Which chromosome?
That familial adenomatous polyposis has APC gene on chromosome. I think it's chromosome. Is this 6? I can't remember, sir.
Yeah, it's the long arm of chromosome 5. It's the long arm
Oh,
of chromosome 5.
5.
Okay,
Okay.
so patients that have adenomatous polyposis coli type of situation gene, they develop colorectal cancer. Yeah, so why this happens? What is APC gene? What does it do? How it prevents cancer? You know that familial adenomatous, yes, excellent. Remas, catenin, beta-catenin pathway. That's the key answer. I love short answers. Beta-catenin pathway. So actually, that was very to the point. I really clap to you, hats off to Dr. Remas, really great. So APC produces a protein called beta-catenin. Okay, it produces a protein which sequesters beta-catenin. Normally, beta-catenin, if it's not sequestered, it goes to the nucleus and stimulates cell proliferation by a pathway called WNT pathway or wingless type pathway. That's all the detail that we need to know. Okay, so someone that have familial adenomatous polyposis, usually when polyps first appear, at which age usually? At which age usually they appear first?
When they are adolescents.
Excellent. Yeah, when they are adolescents, usually starting from age 15, between 15 and 30 maximum, the polyps will appear. And they develop cancer if they are not treated, usually between 30 and 40, or around 40 years of age. Okay, what is the chemoprophylaxis that is done in familial adenomatous polyposis cases? Chemoprophylaxis to prevent or reduce the risk of cancer if the patient does not want to undergo definitive surgical therapy, or is not yet diagnosed but is suspected high. What is the chemoprophylactic agents that you give to this patient? That's a new update in the literature, in the guidelines. That's a new discovery. No, not that new. It was about 4 years back, which is new.
It would it would be a drug that can block the beta-catenin pathway.
Oh my God, I can't laugh because when I laugh, I have pharyngitis. It's just, I'm sorry. Okay, so the question is, in patients that have familial adenomatous polyposis, is there any drug that you can give to the specific drug? Dr. Kuru said a mechanism, but I don't want a mechanism. I want the name of the drug. What is the drug? Chemoprophylaxis. There are two drugs, okay? Celecoxib. You know Celecoxib? Non-steroidal anti-inflammatory drug.
Yes, COX-2 specific.
COX-2 specific. And Solindac. Solindac is also a non-steroidal anti-inflammatory drug. They found that these two drugs, Celecoxib, Solindac, you know, patients that have familial adenomatous polyposis, they can develop desmoid tumor. Is that right? In Gardner variant of familial adenomatous polyposis, they can develop desmoid tumor. Right?
Yes, sir. And osteomas.
Yeah, many other things also, supernumerary teeth, cutaneous lesions, whatever. This desmoid tumor, what is desmoid tumor? It's a locally aggressive tumor of fibroblasts, and it's also called aggressive fibromatosis. It's another name for desmoid tumor called aggressive fibromatosis. It can happen in the abdominal wall, it can happen in the retroperitoneal region, anywhere. They found that when patients, unresectable cases of desmoid tumor, when they give them Solindac, the tumor regress. In a lot of cases, when you give Solindac, which is essentially a non-steroidal anti-inflammatory drug, desmoid tumor regress. They also found that tamoxifen, the one that is used in breast cancer, tamoxifen reduces the size of desmoid tumors. That's the case in actors that you know of against desmoid tumors. You'll tell them Solindac which is a non-steroidal anti-inflammatory drug. And tamoxifen have also been used, and it is having good results. Okay, so let's take last question, which is this one, 51. Yes. Yeah.
From the options listed below, which of the following structures is pierced by the needle first during CSF collection? Ligamentum flavum, epidural, fat, dura, posterior longitudinal ligament, arachnoid mater. It is ligamentum flavum. But before that, there is skin, then supraspinous ligament, then ligamentum flavum.
Yeah, so that's correct.
Then epidural fat.
Yes, excellent. So the skin, sub-Q, supraspinous, interspinous, depending on the angle that you fainted, ligamentum flavum, epidural fat, dura, then arachnoid, then subarachnoid. Yeah, so that's a common question in the exam. Okay, I had fun, really. Did you have fun, guys? No problem? I hope this session was beneficial. And I hope that you're all successful. And I'm praying for you. You're doing well. You're doing a good job. You just have to tawakkul ala Allah, study, keep studying, revising all the time, and you will do more than perfect. I am very sure, more than perfect. And then you will go to the OSCE and pass it, and then do everything in your life. I really wish you the best of luck in every aspect in your life. Okay. So according to our schedule that I posted in the group, we will meet again according to that schedule. If you do have any questions for me, you can call me, text me. You have my number, all of you, okay? So see you soon, inshallah. Best of luck, everyone. See you soon.